Drugs sold under brand names like Ozempic and Wegovy are frequently discussed as aesthetic quick fixes. Clinically, they represent a severe and complex medical intervention. Patients routinely achieve a 15% reduction in total body weight, matched by a 20% drop in major adverse cardiovascular events. But these physical reductions arrive with severe physiological costs. FDA-boxed warnings detail risks of clinical gastroparesis, acute kidney injury, and pancreatitis. These side effects occur because of how the drug actually operates. It does not burn fat. It does not increase your baseline metabolism. Instead, it relies on a chemical override. It forces the body to abandon an evolutionary survival mechanism designed to store energy, the famine protocol. Measuring the true impact of this molecule requires looking beyond the drop in body weight and examining how superphysiological doses systematically hijack both the brain and the gastrointestinal tract. The mechanism begins with a naturally occurring human hormone called GLP-1, or glucagon-like peptide 1. The gastrointestinal tract releases this messenger immediately after you consume a meal to signal to the brain that you are physically full. In its natural human form, GLP-1 is highly fragile. It survives in the bloodstream for roughly 2 minutes before metabolic enzymes destroy it. To bypass this biological limitation, researchers in the 1990s looked to the Sonoran Desert. They examined the Gila monster, a venomous lizard that consumes massive caloric loads just a few times a year. Its venom contains a durable hormone mimic that allows the reptile to maintain perfectly regulated blood sugar during months of fasting. Extracting the biological blueprint from that venom, scientists engineered a human-safe molecule that survives in the blood long enough to systematically change human metabolism. The clinical result of that engineering is semaglutide. This 3D model shows the critical modification. At a specific node known as position 26 lysine, the molecule is altered so it can bind tightly to albumin, a highly abundant protein found in human blood. Once locked in, that albumin protein acts as a physical shield, deflecting the destructive metabolic enzymes that normally tear GLP-1 apart. This single modification extends the hormone's active half-life from 2 minutes to a full 7 days. A weekly injection of this protected molecule creates a super-physiological state. It floods the human body with concentrations of GLP-1 that are 1,000 to 10,000 times higher than the body could ever produce naturally. At this extreme concentration, the drug executes a trimodal mechanism. It simultaneously attacks receptors in the pancreas, the stomach, and the brain. The magnitude of this sustained dosing is the direct cause of the drug's effectiveness and the trigger for its cascading systemic side effects. The first target is the pancreas, which is why the FDA originally approved semaglutide strictly for type 2 diabetes. The drug forces the pancreas to stimulate insulin secretion while lowering glucagon, a hormone that raises blood sugar. Crucially, it does this in a strictly glucose-dependent manner. The pancreas only releases that extra insulin when blood sugar levels are actually elevated. This precisely regulates glucose while preventing the dangerous drops into hypoglycemia caused by older diabetes medications. And the second target is the stomach. This animated cross-section demonstrates delayed gastric emptying. The drug chemically tightens the stomach's exit valve, drastically slowing the rate at which digested food moves into the intestines. The intended clinical benefit is physical satiety. Patients feel entirely full for hours after consuming a fraction of their normal caloric intake. The severe complication is a condition called gastroparesis, or stomach paralysis. In some patients, the stomach's motility slows so aggressively that food sits motionless for days. This leads to severe vomiting, dehydration, and emergency room interventions. This delayed emptying also creates a critical surgical risk. Patients carrying undigested food in their stomachs face a significantly higher danger of aspirating that food into their lungs while under general anesthesia. The precise mechanism engineered to create the physical sensation of fullness pushes the human digestive system to the edge of failure. The third target requires the drug to cross the blood-brain barrier. Once inside the brain, semaglutide binds directly to receptors in the hypothalamus, targeting the exact neural circuitry responsible for appetite control. This chemical binding silences what patients call food noise, the relentless, obsessive psychological desire to consume calories. But GLP-1 receptors are not isolated to hunger circuits. They are densely packed into the brain's reward centers, as well as the area postrema, the brainstem structure that controls nausea and vomiting. Dampening these reward circuits produces a documented neurological spillover. Some users report anhedonia, which is a muted inability to feel pleasure from alcohol, shopping, or normal daily hobbies. This psychological toll is paired with a hidden physical deficit caused by the rapid drop in weight. This visualization breaks down the composition of that weight loss. Clinical data indicates that up to 40% of the mass shed by patients is actually lean muscle, not fat. For younger patients, this is manageable. For older adults, losing muscle mass strips away their primary metabolic sink and the physical safety net that prevents frailty and fatal falls. Silencing the body's natural famine protocol indiscriminately alters human psychology and consumes vital structural tissue alongside the fat. Despite these systemic side effects, the pharmaceutical industry is aggressively iterating on the semaglutide foundation to develop even stronger biological overrides. The next generation of these medications are dual agonists, such as tirzepatide, currently sold under the brand names Mounjaro or Zepbound. This diagram illustrates the pharmacological difference. Semaglutide targets a single receptor, the GLP-1 node. Tirzepatide, however, is a dual agonist, simultaneously activating both the GLP-1 and the GIP hormone receptors. The addition of the GIP hormone creates a synergistic effect. It actively suppresses the nausea signals in the brain while amplifying the metabolic breakdown of fat in the body. The clinical result of this dual action pushes average weight loss past the 20% threshold, effectively rivaling the physical results of invasive bariatric surgery. Obesity is no longer treated primarily as a behavioral struggle. It is approached as a problem of neuroendocrine titration, the precise adjustment of brain chemistry and hormones, escalated through increasingly complex molecules. This approach, however, eventually collides with an inescapable biological reality: the body's memory. When a patient ceases their weekly injections, the protective albumin shields dissipate, and the superphysiological concentration of GLP-1 crashes. This graph tracks patient weight after stopping the medication. Within 1 year of halting the injections, individuals typically regain 2/3 of the total weight they lost. The rapid loss of mass quietly lowers the body's metabolic thermostat. Without the drug to suppress them, hunger hormones aggressively rebound, fighting to restore the original baseline weight. These molecules do not provide a temporary metabolic reset. They demand a permanent, highly expensive lifetime subscription. GLP-1 agonists are a monumental, life-saving intervention for severe metabolic disease. But society must now reckon with the physical and philosophical consequences of treating a highly processed, toxic food environment with a permanent biological override.